Hello all, this is Sue from Weill Cornell Medicine. I'll be presenting a way to characterize tolvaptan response of ADPKD patients. I have no conflict of interest to disclose. So ADPKD stands for autosomal dominant polycystic kidney disease, and it is the most prevalent genetic disease that leads to end-stage kidney failure. Before 2012, there were no treatment available for ADPKD. Then in 2012, this revolutionary paper published in New England Journal of Medicine came out, where tolvaptan, a vasopressin V2 receptor antagonist, was found to delay kidney function decline in ADPKD. Fortunately, in 2018, tolvaptan received FDA approval for use in ADPKD and is now available under brand name Jynarque. So as we discussed in the previous slide, tolvaptan was found in clinical trials to slow down kidney function decline in ADPKD. However, the drug also comes with side effects, most commonly thirst, polyuria, and sometimes hepatotoxicity. Therefore, the FDA requires all patients using tolvaptan to go through monthly lab for the first 18 months, then lab per every 3 months. This also comes with regular visits to the clinic for tolvaptan providers to review lab results with patients. Tolvaptan, branded as Jynarque, also costs around $300,000 per year in the United States. So after balancing the pros and cons of tolvaptan, in clinic, it is only administered to ADPKD patients with rapidly progressing disease, hence Mayo Image Class 1C, 1D, 1E. I'll talk more about this classification system later. Although the tolvaptan temporal trials offered great insights on the general behavior of the drug, there lacks tools to assess individual response to tolvaptan. So let's now talk about Mayo Image classification. There are two pieces of assumptions made in MIC. One is that the HDKV at birth for all patients is 150 ml per meter, and the other is that the kidney volume grow in an exponential manner. We can then plot HDKV versus age on a semi-log plot, and here the star represents the HDKV at birth. Then we can plot the HDKV measured from MRI. By connecting those two dots, we can use the slope of this line to estimate the HDKV growth rate. And based on this estimated HDKV growth rate per year, for every 1.5% interval, we are able to characterize ADPKD patients into 5 classes: Class 1A, 1B, 1C, 1D, and 1E. And Class 1C to 1E represent rapid progressors, where tolvaptan was recommended. To calculate the TKV growth rate, multiple images should be included. Here, for example, each image represents a time point on a semi-log plot of the HDKV versus age. Although the patient was estimated to be MIC 1B, the true kidney growth rate is 5.1% per year, which indicates the patient is more likely a rapid progressor similar to MIC 1C or 1D instead of 1B. At the Rogerson Institute, our nephrologists have been following ADPKD patients for over 20 years, and they've been administering tolvaptan since phase 3 trial. This allowed us to plot the kidney growth trend for individual patients. For example, in this patient, the kidney growth rate before taking tolvaptan was 3.4% per year, and after taking tolvaptan, the kidney growth rate lowered to minus 5.6% per year. Thus, we are able to conclude that this patient responded to tolvaptan in terms of kidney growth rate. Well, here is another example, but in this case, patient's kidney growth rate was 3.9% per year before tolvaptan. However, after the patient started taking tolvaptan, the kidney growth rate increased to 9.2% per year. This raises the question, are all patients benefiting from tolvaptan? So, in order to answer this question, we found 32 ADPKD subjects who were rapid progressors who took tolvaptan and had 2 years or more imaging follow-up before and after taking tolvaptan, and 18 of them were kidney growth rate responders. Unfortunately, the other 14 of them were kidney growth rate non-responders. Visually, the change in TKV growth rate before and after taking tolvaptan among the 32 patients identified can be divided into two groups. We then further analyze the relationship between TKV growth rate response versus kidney function response by plotting change in eGFR versus month since tolvaptan initiation. While TKV growth rate responders had an average kidney function decline of 0.25 per year, TKV growth rate non-responders had an average kidney function decline of 0.43 per year, almost double the rate of eGFR decline of responders. Therefore, tolvaptan responders have a statistically significant reduction in eGFR decline compared to tolvaptan non-responders. We further examined the characteristics of responders versus non-responders at the time right before tolvaptan initiation. Surprisingly, age, BMI, male image classification, and eGFR cannot be used to identify tolvaptan responders from tolvaptan non-responders. On the other hand, baseline TKV growth rate and baseline spot urine osmolality are statistically significantly different between tolvaptan responders and non-responders on univariate analysis. To validate this finding, we performed multivariate analysis, and both parameters stayed significant. Visually, this gap shows difference in the baseline kidney growth rate between tolvaptan responders and non-responders. In summary, our study established a method to evaluate tolvaptan treatment responses using TKV growth rate calculated from series MRIs. So in order to provide this tool to all patients and all providers, we are working very hard to make this available at revalueai.com. Here is a QR code for more information if you also want to make this kind of graph for your patients. Thank you so much for listening. Please feel free to ask any questions in person at ISMRM or using any of the platforms provided below. I'm super thankful for my team and Dr. Prince for all their supports. And please reach out, and thank you.